See you all. I'm Nick Prince, one of the PICU consultants at St George's. Also, Jatinder, his co-lead for STPN critical care on the medical side with Jatinder. Nice to see you all. All right, I do want this to be, if we can, a little bit interactive. So I'll put some uncomfortable pauses in when I want people to speak, if that's okay. So please do unmute and speak. Some of my team's in the seminar room on PICU, so worst case, they'll have to stump up and say something. Otherwise, I'll be after them. These are the things we'll look at. So we're going to think about the sicker child and navigating them through anaesthesia and intubation for asthma. So we'll think about physiology, the interventions we can do, medications, anaesthesia, intubation, and obviously what can happen during and after that. All right, so let's base it around a case. You know, imagine this is any child you've seen. It's the X-ray of a slightly older child, so a sort of young teenager with a known history of asthma, has had previous exacerbations before. They may or may not have been to ITU, intubated before, and on this occasion, let's say they've had a cough and a cold, not been feeling very well at school, have sort of become increasingly short of breath, and have kind of worked through the home cycle of escalating nebulizers along the lines of what Jatinder was talking about, and then actually comes into hospital and works through the kind of immediate hospital management. So they've had burst therapy, they've had steroids, the team have tried some magnesium. All of those things may or may not have helped a little bit for a while. But let's imagine this young person is looking tired, working very hard with their breathing. Chest is either very wheezy or heading towards the quiet side. And let's say, for the sake of it, you did a gas and it is becoming to lean more towards acidosis. So a moderate asthmatic, as you know, should have a slightly alkalotic gas, shouldn't it? Overbreathing, CO2 is low. And when it normalizes and certainly goes up, that's a sign of decompensation or tiring, deterioration. And, you know, maybe your SAT's now at 88% on 15 litres via a mask. So, question to the crowd then. So what's happening with this child? And ultimately, what are our big decision options at this point? So they're on a face mask, they're struggling, and there's plenty of evidence that they're doing less well rather than better, having gone through all the standard management. This is the uncomfortable silence where someone has to say something.
Do you question if the child needs some high flow, perhaps?
Okay, so let's say that's an option, high flow, and we heard a bit about high flow already. Okay, so that's one option. Yep, what else?
Recognize that this is just going to a sort of life-threatening situation, especially if he's not talking and is very weak. Yeah, he might stop breathing.
Fair. So that's kind of human factors, recognizing the situation you're in, and probably verbalizing that out loud to make sure that the whole of your team understand your train of thought.
And contacting your sort of anesthetist, I guess, priorities. So at any time, you know, you need to escalate, then at least the team is ready and it needs an assessment.
Yeah, absolutely. So corralling your team, working out who's around, and actually probably beginning to assemble your team based on what you're going to decide to do. So again, just that question again, what are our decisions to make? So Optiflow is one option.
If magnesium sulfate was not given before, time to give one.
Yeah, and if it did work, you could give another dose, couldn't you? But
yeah,
let's assume we've done everything that Jatinder's talked about and the child is in this condition. And you know, things like if you hadn't started IVs, you could. Yep, go ahead.
Adrenaline?
Ooh, adrenaline. That actually doesn't tend to be on... you know, it's a very beta agonist drug, isn't it? But we tend to go for beta 2 selective agents. So you should probably have given lots of inhaled salbutamol, say. If you haven't already, you should try IV. and we'll come on and talk a little bit more about that. So you've got the options of IV salbutamol or aminophylline, and we'll come back to that. But I suppose your big decisions at this point, if you truly have done all of that, is between some sort of non-invasive support, if you really think there's some merit to that, versus actually making the decision to intubate. And then someone just tell me, what is the pathophysiology for this child in this position? What's actually going on?
I have trapping and
Say again. I think two of you are going to say something. Go on, say it again.
yeah. I mean, there's significant air trapping on the X-ray. He's getting really tired, so probably his respiratory drive, and in a way he can he's actually compensating to that extent that decompensating to that extent that he might crash any time. Yeah, so it is.
Yeah, so lots of air trapping, very hyper expanded. And actually, if you look, there's those kind of high, low and lower down sort of streaky changes. So no obvious big focal pneumonia, but actually what this child has going on is obviously bronchospasm. That's what asthma is. And then all of the inflammatory sequelae as well. So particularly thick, viscid mucus production. And actually you've probably got at this point, for this child, potentially irreversible on their own plugging of their kind of their airways, essentially. So thick, inflamed, bronchospastic, but also full of mucus, and that's often the end kind of pathway prior to intubation. A lot of your treatments are obviously focused on reducing the inflammation, trying to stop mucus production. Ideally, the patient needs to sort of cough it out, and when they can improve. But you may end up in a kind of irreversible heading towards intubation, and there's not really much you can do about it. And if you've given all the medicines and it hasn't got them into a better situation reliably, then that may well be the writing on the wall. You do have the option of things like Optiflow and non-invasive pressure ventilation. We'll talk a little bit more about that at the end. I think what I would say about that is if you go back kind of 5 or 10 years, it was an absolute no. People thought that was a terrible idea. Increasingly, we do get some children through on our unit who are sort of not disastrously bad, but struggling, and we will get a few through. But I think the caution with non-invasive is not to push these children way beyond what they can cope with, not to fool ourselves. We're making them better with non-invasive, and actually when you do come to anaesthetize them and intubate them, you've actually pushed them even further down the line of unstable, risky, decompensated physiology. And this is just a nice little graph just to remind you where in our airways most of the resistance sits. And actually it is the kind of large and mid-sized airways. And they're mostly the airways which are getting inflamed and blocked up in asthma. All right, that's for medical management. Really, you've covered there with Jatinder, and we've talked about it. Physiotherapy can be a mainstay of getting out the sort of mucus plugs, but in reality, that can be very difficult without them being intubated. And really, you just need a child who you can loosen up the secretions, open up their airways, and they can cough it out fundamentally. So again, once they've got to the point that they can't, then really you need to look at other options. And I think for the purposes of safety today, we'll talk about progressing to intubation rather than getting in too much about non-invasive, although, as I say, we will come back and touch on that a little bit. All right, question to the crowd. Lots of you will have started IV salbutamol, you'll have bolused it, you'll have escalated it as a continuous infusion. Some of your centres may go for aminophylline, and some of you might start with one drug, and if it doesn't seem to be working, you might swap over and start the other drug. Salbutamol, you know, is a beta-2 selective or semi-selective agonist. Aminophylline is a xanthine, which is actually what is in caffeine or coffee. My question to you all is, let's say you bolused and started salbutamol and it doesn't matter if it worked or not or made them better. Let's say it did make them a little better, but then you do a gas and the lactate's 4 and then it's 6 and then it's 7. What would you be thinking? Why has it happened? And what will you do about it? And should you do anything about it? Someone's got to be brave and say something.
Hi, I'm Emma. I've seen it in, not so much on the infusions, but when we've got probably a bit carried away with nebulizers, and they've been on like hourly nebulizers for a while.
Yeah.
Really, the lactic acidosis that you get to, that I would put down to being likely the salbutamol, and I would try and rationalize where possible, because I think sometimes we're a bit gung-ho at doing it by rote, and just putting them on like hourly, and seeing if we can reduce it, look at their fluid status as well, and obviously look at any other causes of a high lactate. But where possible, I would try and rationalize the salbutamol.
Yeah, and by rationalize, do you mean give less?
Yeah.
Great. That's a lovely answer, actually. So, and yeah, it can come from NEVs rather than IV, can't it? Essentially, it's about having a lot of salbutamol in your body, and at the same time, the child's probably going to be quite tachycardic, jittery, and all the other problems that come with lots of salbutamol, like low potassium. All right, so what is happening, and should we be worried about it? Okay, this is, oops, I'm pushing the wrong computer keyboard. This is your glycolytic metabolic pathway, and that's a nice fancy picture, and I quite liked it, but actually we'll use a slightly older fashioned, simpler one. So most of you probably know that when you want to make energy, you break up glucose, it gets converted down through that chain and ends up, right? And then ideally, if you've got plenty of oxygen, it then crosses over to become acetyl-CoA and it enters your Krebs cycle in the mitochondria. We are used to worrying about lactate as a sign of anaerobic metabolism, or let's say lack of oxygen. Okay, so anaerobic metabolism we get if you do a big sprint and you exceed your aerobic capacity and you're making a bit of lactate in your muscles. But obviously, clinically, the big one we worry about is sepsis, where you have inadequate oxygen delivery. And you build up lactate because you just can't convert enough of the pyruvate to go through to acetyl-CoA. So the pyruvate builds up and then it shunts sideways into lactic acid. So it's one of our biggest markers of oxygen delivery failure, and sepsis really is what we're thinking about, and it worries us, and it should worry us because it shows your metabolism is on the limit. Now that could be the case in asthma. It may be going up because, as you said, fluid status, they could be dehydrated. They might have been febrile, they'll have been breathing very hard, lots of insensible losses, and they may not have been drinking enough. That could put your lactate up a bit, although I wouldn't necessarily expect it to put it up into really high numbers unless they're in a lot of trouble cardiovascularly. More actually, so salbutamol drives glycolysis, and it drives a lot more glucose to go down into this chain. So as an adrenaline-like compound, you get loads of glucose pouring in down this pathway, and actually pyruvate can build up at the bottom simply because you've put a lot of substrate in at the top, and then some of that gets shunted off to lactate simply because you've got a huge amount of glucose coming in at the top. So if that's the case, then actually we shouldn't be quite as worried, let's say, that the lactate's gone up. It's predictable and it's understandable, and it isn't necessarily a sign of shock or poor perfusion or poor oxygen delivery necessarily. But your comment actually about checking out that theory is completely appropriate. So, the tachycardic asthmatic with a lactate going up, 100% I would give a little fluid bolus to and just see if that makes any difference, and do a full fluid assessment. Are they weeing? Do they look dry? Do they feel thirsty, etc, etc. So for me, it doesn't necessarily mean you have to switch to aminophylline, which is what a lot of people sometimes do. But I would take a view as a whole on, is the drug working? Are you going to be able to wean it a bit? If not, then maybe aminophylline as a tryout is going to be appropriate. The other thing to say is salbutamol, people used to give it in really high doses. If you look at some of the early papers, it can be even 5 or 10 mics per kilo per hour. I think most people's guidelines in recent years have been a max of 2 mics per kilo per hour. And actually a lot of centres have brought that down to 1. So if you can be on a half or 1 mic per kilo per hour, that's good. And if you're not, then do try and bring it down to those levels. With regards to which drug you pick, I think either is fine. If there's a history that they've been sick before and one drug worked, obviously it makes sense to go for that one drug. So that's lactate, salbutamol, and aminophylline. All right, let's say we have made the decision that this young person needs anesthesia, intubation, and mechanical invasive ventilatory support. Okay, these are the kind of steps and choices that we need to think and make and do. In broad terms, let's just think about the anesthetic approach. In broad terms, someone shout out and just say, what are the things that are going to particularly worry you about giving an anesthetic and intubating and ventilating an asthmatic?
They're going to need very high ventilatory pressures. That
may well do.
Might not, that might cause people to think maybe the tube's not in the wrong place or something, when actually you're just not able to move the chest.
Yeah. So it's worth knowing that. And often actually the patient is doing a very good job on their own, and we would be foolish to think that we can easily replicate what they were doing. So yeah, may need very high pressures to actually move the chest, inflate their chest. Yep. What else? Risky or not risky, or somewhere in the middle?
Yeah, very risky.
Okay, why is it risky? So it might be difficult to get gas into the chest. What else is risky?
They often get gas trapping and CO2 trapping.
Yep. So we'll come back to that actually, but yeah, it can be difficult to get the gas in, but it's also very difficult to get it out, isn't it? That is the fundamental problem in asthma.
And it also depends on the choice of the agency you use to induce the anesthesia, and they might react very badly with the fallen blood pressure and things, and one has to be careful in terms of use the appropriate agents.
Yeah, great. Does anyone want to offer some drugs that they may choose to anesthetize an asthmatic?
Some ketamine.
Ketamine.
Ketamine, great. So that's an anesthetic agent. So anesthesia has 3 parts, doesn't it? An anesthetic agent. Actually, ketamine, it's arguable if it truly is an anesthetic agent, but we'll say it is for our purposes. And then the other 2 components are an analgesic
Sedation. Analgesic and sedation.
Yeah. So analgesic, pretty much always fentanyl. Ketamine, as you guys said, and pretty universally in emergency scenarios these days, adult and pediatric, rocuronium. If you give a milligram per kilo, you get a good onset of intubating conditions within 60 seconds. So as good as succinylcholine, and it's obviously non-depolarizing. There are other agents, propofol. In expert hands, it can be okay. Propofol drops your blood pressure a lot, certainly to be avoided sepsis. For an asthmatic, I just think, if it's expert hands and they want to, it's not a definite no. But I think anyone who's kind of pediatric, then in our minds, we should just have ketamine, really. And then slightly older fashioned things like thiopentone would have been the classic rapid sequence induction drug. Propofol is the more modern, modified rapid sequence induction drug. But actually ketamine, fentanyl, and rock for our purposes are what we would use. The gas sevoflurane is there, and we'll come back to that again. But ketamine and sevoflurane, what what properties do they have which also may make them quite useful or theoretically beneficial?
Bit of bronchodilation, I guess.
Yeah, allegedly they give a bit of bronchodilation, and again we'll come back to that. Ketamine also can make you produce a lot of secretions as well, which can in themselves be problematic. Right. At times, I think it's useful to think of all the things that could go wrong, and then that allows you to work backwards and think, how would I prepare for it? How would I minimize the risk of it happen? And also, if it does happen, then I can be a little bit more prepared with my team. You know, this is a child where you may want to pre-allocate some roles for an emergency situation, and you might want to just think through, look, if something's gone badly wrong, what might have happened? So give me a few things. Let's say this child either desaturates heavily in a problematic way or has a cardiac arrest. What's happened? Okay, the desaturation, someone's already said breath stacking, so I'll put that on the table and we'll come back to that. Let's say they arrest. Why might they arrest? And what can you do to prevent it?
Nick, someone's mentioned something in chat about pneumothorax.
Okay, pneumothorax. I can't see the chat actually very easily. Just say things if you can. Okay, pneumothorax, well worth thinking about.
Yeah. Significant drop in blood pressure, cardiac perfusion leading to arrhythmias.
Yeah, I mean, arrhythmia, possible. Your potassium might be low. You'd want to be looking for that.
And sometimes salbutamol overload, everything sort of makes the myocardium excitable, and with hypotension, hypoxia.
So let's just follow the low blood pressure. And we talked a bit about anesthetic drugs, so we've thought about that already. Why might you get sudden, very poor venous return or cardiac output in this child at the point of intubation? Can anyone think why your cardiac output might suddenly drop in this child at intubation?
There's a venous return, isn't it? Yeah.
Yeah, so just tell me a bit more about that.
You're applying a lot of
Your
positive pressure.
colleagues make you work hard. Yeah, carry on.
You're applying a lot of positive pressure to the chest, and so that will squeeze and impede your venous return.
Yeah, exactly. So actually, when an asthmatic's breathing, they're putting in a massive effort, which generates a negative pressure and sucks air into their chest, doesn't it? So their chest, although it's got trapped air and maybe under pressure, actually they're breathing in a negative pressure fashion. And then you're switching immediately over to positive pressure, and you've already said potentially very high positive pressure. So your intrathoracic pressure goes from negative, which is good for venous return, to probably very high positive, which is bad. And then we've already said the child may be a little dehydrated, intravascularly deplete. So, you know, the prevention strategy for that is consider, and to be honest, give a fluid bolus at or prior to induction. You know, fill them up a little bit, make sure they've got a slightly more reserve in terms of venous return. High pressure to oxygenate, ventilate, we've talked about. Pneumothorax, we've talked about. Now, breath stacking. You can do this to yourself, okay? Breathe all the way in, breathe out only half the way, breathe as much in as you can again, and only breathe out a tiny bit, and then breathe in as much as you can again. You get that kind of feeling of your chest wanting to explode, don't you? And you can't actually breathe in anymore. So that's sort of what breath stacking is. With each breath we put in, we don't get all of it out. And if you keep doing that, actually very quickly, you can end up hyperexpanded lungs, which you can't easily empty, massive intrathoracic pressure, and you end up not being able to ventilate. The patient starts to desaturate, and actually you'll get venous return problems again as well. And these graphs just give you a little bit of an idea of that. But if you did that breathing exercise, you'll get it as well. You can easily breath stack someone by being stressed and overexcited and getting the tube in and then bagging them very, very quickly, or even moderately quickly, to be honest. So the trick is give enough pressure to inflate the chest, and give plenty of expiratory time for the gas to come out, and just really slow yourself down. You might need to ventilate them in hard, but make sure you give them plenty of time for the gas to come out. Okay, and that will lead on to a ventilator strategy. You can breath stack them very quickly. And then really the other complication is, what if you've got the wrong diagnosis? So actually, what if it's a mediastinal mass or some other chest mass? What if actually when they got better with steroids 2 weeks ago, it was because you treated their lymphoma with steroids without realizing? And as Jatinder said, I think first wheezy episode, that's why a chest x-ray is so important. Just occasionally there'll be a child who's actually got malignancy and it's missed, and potentially partially treated with steroids. You can't see that, but if you've got a desaturated intubated child, we should use the DOPES algorithm. So displaced, is the tube actually out? Obstructed, is it blocked? So put a suction catheter down and check. P, think about pneumothorax. E, equipment. So if you're on a ventilator and they're desaturating, best to come off and use a simple bag circuit and test them out. And then S in pediatric is the stomach. If you've got a massive gas-filled stomach from being bagged at anaesthetic, and you need to empty that. I don't think this projects very well, and it's not an asthmatic, but can anyone see anything there that's a problem and tell me why?
The tube is too low on the right side.
Yeah, very good. So you can almost see it, can't you? I can't get my pointers to come up, but the tube is probably at or just in the right main bronchus. That means you're not ventilating the left, so it's lost its air and it's gone white. And actually, if you look carefully, you can see a black line, which is the right lung being overinflated and herniating across. And this isn't an asthmatic, but it is something, again, if you're excited and don't want the tube to fall out and put it in too far, this just highlights why precision is important when we're looking after children. Okay, this is a bad and obvious one. This is a neonate, not an older asthmatic, but bad pneumothorax. And then this is an even worse bilateral pneumothorax. Again, not an asthmatic, but just, these are severe examples. Don't expect subtle pneumothoraces to look like that. And then finally, mediastinal mass. These again are both extreme examples. So you need to be able to spot slightly more subtle mediastinal widening. On the right, a neonate with a huge mass, and on the screen left and on the screen right, an older person with, again, a very huge mediastinal mass. And these can cause respiratory symptoms, worse when you're lying flat, both airway and venous return issues. And if you anaesthetize and try to intubate these, you may have catastrophic loss of cardiac output, inability to ventilate, and it may be irretrievable, especially if you don't realise what the problem is because you didn't know beforehand. So mediastinal mass is to be thought about. Have a chest x-ray, and treat with extreme caution. They shouldn't be anaesthetised. Right, quick summary of what we've talked about so far. Ketamine and sevoflurane for bronchodilation we've talked about. There is this issue of histamine release making asthmatics worse. Fentanyl induction is fine. Some units will use fentanyl as their sedative agent post-intubation. It's not absolutely necessary. On our unit, we'll still use morphine for most of our asthmatics, other than the really, really, really severe ones. Morphine theoretically releases more histamine than fentanyl. And again, there is a theoretical difference between the muscle relaxants in terms of histamine release as well. Again, it's not, to be honest, usually an issue. Cuffed ETT, absolutely essential in anyone, I would say, being intubated, but certainly if you're going to need high pressures. If you do a risky, dangerous procedure and put the wrong tube in, you and the patient may heavily regret it. You don't want to have to do twice something which was difficult enough the first time or risky enough. And then ventilation, I think we've pretty much talked about this. So you want a slow rate, maximum 15, good long expiratory time, enough pressure to move the chest, but give them a good long expiratory time, enough to get as much gas out as you can. This is a ventilator display. The middle line is flow. When it goes up, that's gas going in, and when it's below 0, that's gas coming out. And if you look in this patient, you don't have that flow line coming back to 0 before the next breath goes in. And again, if you look at the volume curve at the bottom, you don't get the volume back down to 0. So that's a sort of warning sign that you might be breath stacking your patient. Okay, anyone that's worked on PICU, the bit you can see at the moment on the screen is the kind of pre-intubation management. Once you're intubated on a PICU, have people seen subtly different ways of actually looking after these patients? Anyone want to give me their experience?
No more nebulizations?
Okay, so, yeah, that's part of one of the strategies. What else?
And typically in children, for other ventilation, they go by the age and give a big number of breaths. Whereas in asthma, you're probably going to, as you said, have a high expiratory time and low rate and enough.
Yeah, exactly.
Enough,
definitely
high
true.
time, yeah.
Yep.
And then physio.
Very good, very good. Okay, so I think in the UK we've got a bit of a dichotomy of how people with asthma get managed. And I think it's an evolving, changing process, but broadly units can fall, I think, into a little bit of two different camps. So the one extreme camp, let's say, is to stop all the bronchodilators, recognise they weren't working, the child had gone beyond that point. The problem actually is mucus plugging, and therefore you want to do physiotherapy. You may well use DNAs, either directly instilled or occasionally nebulized, which will certainly be less effective. The DNAs breaks up the viscid proteinaceous mucus, and then you can physio it out. And just occasionally you can do that either bronchoscopically guided to insert the DNAs or to suck it all out. But usually you can get by without bronchoscopy, to be honest. And then there's the other camp, which is giving even more of the drugs that you've already given, lots of salbutamol or aminophylline, using fentanyl instead of morphine. That's okay anyway. Some centres will start IV magnesium infusions to bring up the magnesium level on bloods. Some will do ketamine infusions, and just occasionally people even will use sevoflurane via an anaesthetic machine. I think less these days. So you've got the kind of mucus plugging physio DNA side, or you've got the give lots of drugs side. And if you've worked on a PICU, you'll have seen that done in different ways. At George's, we're very much towards the left side, but a slightly sort of moderated approach. So we do tend to give a little bit of salbutamol and ipratropium by nebs, but probably only 4 hourly, possibly 2 hourly. We'll come off and stay off IV drugs usually. We certainly wouldn't give ketamine IV or magnesium infusions IV. And then we will definitely focus on DNAs and physiotherapy and clearing out the chest. And actually, if you do that, a lot of these children who were desperately sick, you can actually turn them around, sometimes even in less than 24 hours, and get them extubated the next day or the day after. So they're the kind of two different ways of doing it that you'll see. The downside of the drug route is it often doesn't work. They can be intubated a very long time, and you start to get side effects of all of these drugs. If you're on a ketamine infusion for a number of days, you'll be a little bit loopy afterwards. And again, it's just going back to that pathophysiology. The problem is mucus, so actually getting the mucus out and waiting for the steroids to work for inflammation and stopping all the other drugs is often the way to go. Briefly, just a couple of things to touch on, and then we'll stop for questions. As I said, everyone these days really should be getting cuff tubes for any reason, I would say. Even the units that didn't used to like cuff tubes these days pretty much use them as a rule. And in part, that's because technology's moved on. So the tube you can see on the left here is called a micro cuff tube. The cuff is like cling film, and when it's deflated, it's pretty much like it's not there. They were made by Kimberly-Clark, who became Halyard and then became a different company name. Reason people didn't used to like cuffs is if you look at the picture on the right, the cuffs used to be quite stiff, and when they were deflated, you'd almost get these kind of blades sticking out the side, and they could cause airway trauma. The other thing is manufacturing. Different manufacturers would have the cuffs, different sizes, different places relevant to the tip. And, you know, that meant that exactly where the cuff sat, you couldn't necessarily be sure, and it could be causing more trauma as well. Final bit to talk about is functional residual capacity, which I used to kind of hate as a concept and now actually quite like. If you were to anaesthetize me now, being quite well, and you gave me 100% oxygen and then muscle relaxed me and then didn't ventilate me, how long would it take until I desaturate? Offer me some numbers. Anyone know? Deathly
30
silence.
seconds to a minute. Hazarding a guess.
That's a good guess. Any other offers? So I don't know if people will be surprised or not, but you might get 7 or 8 minutes before I desaturate. So you could muscle relax me and walk off. And as long as the queue in prep's not too bad, you could get a coffee and come back. And I'll probably be okay. Don't recommend that, but you'd probably be okay. And actually, this graph helps us understand that. So, you know, normally sat here now, we're doing little breaths somewhere in the middle of our lung range. You know that if you take a deep breath, you can really fill up your lungs. And also you can actually breathe out a bit further than where you normally breathe out to. But of course, even when you've done a big breathing out, there's still some residual volume in your lungs. So, you know, if our lungs are sort of 5, 6, 7, 8, 10 litres and you fill that with pure oxygen, then it's a bit like being a camel or an astronaut with oxygen tanks. You've got 10 litres of pure oxygen in your body. And, you know, you can do the calculations how much oxygen a healthy person's using, but your body can just sit there slowly absorbing the oxygen and you don't desaturate. And this kind of graph of breathing in and out and volumes maybe helps you understand that a little bit. That's why for any sick child, it would be important to pre-oxygenate them before you actually start the anaesthetic. But of course, they'll have a higher metabolic rate, much less expiratory and residual volume. So you should expect them to desaturate potentially quite quickly. But nonetheless, pre-oxygenating and filling up their lungs with pure oxygen is going to be very important to buy you a little bit of time. Last thing I think we'll look at before we go is just end tidal CO2. So normally it's quite a nice square wave. Your end tidal should be 0 when you're breathing in, nice fresh gas, no rebreathing CO2. And then when you start breathing out, a bit of dead space comes out, and then you plateau up to your end tidal. In asthma, your end tidal can look like this. So my question is to you, why does it look like that kind of shark fin appearance? So that's a sign of expiratory obstruction, but why? Why is that expiratory obstruction? Molly, we'll stop any minute, I promise.
No, that's all right, don't worry.
The minute someone's told me why the curve is this shape. So we'll look at this graph. For your end tidal to measure, you have to get CO2 from your lung up to the sensor, which is just outside the nose. The first bit that comes out is actually dead space, which should still be fresh gas because no CO2 will have gone into it. Then the next bit that comes out is from the large airways, and only towards the end of breathing do you get the really dirty gas full of CO2. Now, in a healthy person, that dirty gas from deep down comes out very quickly. So the curve goes up to maximum and it's largely flat, but with a very slight upslope. In asthma, it's got that curve because it takes a really long time for that dirty gas to get out. Okay, now that leads you to think, let's say the ventilator's set at 15 or 18, someone set it to 18 and I'm not happy, I come over and their gas is acidic, pH is 7.2, CO2 is 8 or 9, and I turn the ventilator down, so I change the rate from 18 to 15 or 12, and then I walk off, because that's what I do things and walk off. And then I get called back by the nurse or the SHO and say, what have you done? Your end tidal was 6 and now it's 8. We want the CO2 to go down and not up. So what just happened? And should I reverse what I did? Someone's got to say something.
I'm going by the leading question that you did the right thing.
Yes.
I think it takes time to stabilize, isn't it? You can't.
Yeah, exactly. So your blood CO2 is only going to go down, isn't it, if the CO2 can get out of your body. So if you look at that shark fin, if I sped the ventilator up, you'd cut the shark fin off sooner, wouldn't you? Which means the peak would be lower. So your end tidal would go down, but actually you're getting less CO2 out of your body. The CO2 coming out of your body is proportional to the area under that curve. Conversely, if I slow it down and you allow the ventilator to carry on letting the patient breathe out, you can imagine that shark fin will go up higher. You're getting more of the dirty gas out. Initially, your end tidal will appear to go up, but actually that's a good thing. You're probably getting more of the dirty gas out of your body. So we are going to stop there.